Thank you, sir. Thank you, Jospo. A warm welcome to all my teachers, my friends, and my colleagues. In the next few minutes, I bring you greetings from Christian Medical College, Vellore. This is our Ranipet campus, and the outline is what I have listed here. And just before I go to the talk, I have a disclosure to make. What I am going to be saying in the next few minutes is what I'll be echoing what Dr. Feroz said, and also what Dr. Siddharth and Ankit had also mentioned. So there's a significant overlap, but I'll go straight to the meat. So this is a brief outline. And in the introduction, definitely a compatible graft shortens the waiting time, increases the graft survival, and has a less sensitization during the transplant period. It can lower the waiting time for a retransplant. And with a compatible graft, the use of immunosuppression, you can reduce the rejection episodes, infections, and death. A compatible graft has a least chance for alloantibody formation. However, said that, the introducing of HLA-DR incompatibility, the effect of HLA-A and B compatibility has come down or disappeared. So it's challenging for a nephrologist for the complexity of the transplant tissue typing, the expanding list of HLA alleles, the significance of allele-specific antibodies, and the polymorphisms in HLA, which are introducing new concepts of epilept, eplept, and so forth. So looking at the timelines, when we look at it, most of these have come out over a good series of time, and we almost have, as we said, 15,000 to sometimes 40,000. But when you look at compatibility in renal transplant, what is compatibility? Two things that can exist or occur together with no problems or conflicts. Now that is the graft and the recipient. And to have a true compatibility, you need to have a deeper alignment in the life goals, that is the patient and the graft outcome. The communication styles also leads with the compatibility. That's the immunogenicity that we need to deal with. And in this immunogenicity, the emotional temperaments that can affect a relationship, that is the HLAs, DSAs, and the eplets, and how well we navigate all these are the challenges together that we face. Those are the mismatches, assessing the risk of the de novo DSAs, supporting each other and trying to be wise so that we can allocate an organ properly or do a good matching for a good organ to be received by a recipient. And understanding and respecting individual recipients' differences so that we can proceed with precision medicine. So which is more important for incompatibility? HLA mismatch. I'll just quickly go through it. Now, by the time Firoz's talk was over, probably you would be wondering whether HLA typing needs to be done. By the time Siddharth and Ankit had finished, people were saying whether CDC should be done. I'm here to say that HLA typing is to stay for the simple reason for the evolution that is happening with the HLA that is happening, the genetic polymorphisms. And no doubt, it is a significant barrier to transplantation when it looks for the survival. It is also, earlier studies had shown that it's a predictor of clinical outcomes. And with advancements in treatment, especially for the T-cell mediated rejection, there is a lesser understanding of the humoral allo response, which is an important cause for chronic allograft loss. HLA typing is important to understand or prognosticate the risk for developing a donor-specific antibodies. And there are already evidence of DQ, DR, now HLA-C and DP antibodies which are playing a role in antibody-mediated rejection. So with all the Western countries that are changing their allocation systems based on this, it is very clearly evident that the current kidney allocation is inconsistent and not perfect. And our country, along with all of us together, we need to put out an appropriate allocation system which includes understanding what a patient needs. So this was one of the articles that I looked out and which actually substantiates saying that HLA still has an important role to play. So when you look at the forest plot, I'm not sure how clear it is, but this forest plot definitely says the HLA per mismatch has an overall graft failure, and you see most of the studies, the dots are right at the center, all the most significant. When we look at this association of HLA, A, B, and DR mismatches, the association is even more stronger. Furthermore, when we look at death-censored graft survival, there is no doubt how important it plays. Similarly, with an all-cause mortality, that's the patient survival, HLA mismatch definitely plays a role. And this was the meta-analysis that looked into it and said HLA mismatch is a critical prognostic marker. An incremental increase of mismatches shows a higher risk of overall graft failure and death. The DR mismatching, the sample size that we used, though it was considered small, they still said it has a significant role, probably increasing the population or the numbers. You can see the significance of HLA-DR matching. And this paper analysis showed how much influence of ethnic diversity is there, which we all need to understand that our cohort is totally different from the Western or that has been reported in literature. So HLA mismatching has a significant role. Before we all decide whether HLA mismatching needs to be done or not, you need to understand, I'm cutting straight to the review of literature for the last 15 to 18 years that we have out here. And one thing that we need to understand when we read all the literature is how much you can decipher from it and how to apply it to our people. So as a clinician, for me, it is very important. And the crosstalks with the lab, a very good lab, is to facilitate a very safe transplant. It is not to do a transplant, but it is to facilitate a safe transplant. And that is what we have all been taught for. And for that, standard definitions need to be used when you're interpreting, which compare the immunological risk, molecule serology, and the cell-based methods, assessing the prognostic significance of HLA incompatibility to renal transplant and its outcomes. So these were some of the definitions that were used, which has been proposed in 2022 to look prospectively. When I go down to my next few slides, you will understand the review of literature of how much role it has played to change the way we are looking at what is outlook. And echoing again what Dr. Feroz says, epilept is something that we need to still work on, or matching is something that we need to work on. So, is it a time to move on with HLA matching? Should be considered in modern disease donor kidney allocation, which is not happening in certain parts of the countries. This is the journey that the patient goes through. Mismatch transplant recipients have a very high prevalence, and what you see in the pink is something that you need to understand. That is not the only problem that a patient faces. Mismatch also has shown significance in increased incidence of coronary artery disease, diabetes, and a high prevalence of diabetic nephropathy as a primary renal pathology in these group of patients. So it is not just the immunological journey that they go through. There is a non-immunological journey that patients do go through which affects their outcomes. If you look at this over a period of time, you see that the mismatched donor recipients who had received an organ, the GFR is definitely a bit lower. Though they start off a bit low, they tend to remain the same. So there is something else that is happening that keeps them going. So I'm just taking you all slowly into the concept of whether it should be applied for all or for few selected patients. If you just look at this, you'll say, okay, a less mismatch HLA has a poor outcome. So with that, I would say HLA typing should stay. It enables to improve the donor-recipient HLA matching, reduces the exposure to immunogenic alloantigen. Sensitized patients is something to be looked at, and how are you going to look at has to be noticed. Remember, there has been very inconsistent reporting, and more focus should be on DR-DQ mismatches. What is the current limitation in the HLA system? We all know that with the resource-limited settings, you're not able to have a high-resolution technique, so most of the places may be using low-resolution technique. But what my question to you all is, a patient invests a considerable amount of their lifetime expenses to do a renal transplant. So it's about time we, or the transplant centers, invest in ourselves to develop a very good lab so that you can facilitate a very low transplant. So high resolution typing is the way to go forward, and it's about time we start thinking of investing it to get a very good lab, not only for the state, but for the country as well. Remember, it fails to address two important aspects: the relative immunogenicity of specific mismatches when you read the literature, the risk for cross-reactive antibodies developing following alloimmunization. A broad sensitization is differing among the HLA alleles. It has gone down now to few amino acids, whether they are small, large, polar, non-polar, which will give you the T cell immunoresponse, gives you a very different picture. So why does this happen actually? The same concept Dr. Feroze had mentioned, it's all about to do epitope. I'm not going to spend much time, but remember it is all to do, started off with the CD regs of the paratope in which the antibody binds to the antigen, the amino acids, and the epitope in which that is. This diagram has been repeated from morning, and the only diagram that I like you all to concentrate is on the diagram number B. The yellow represents the functional unit of the epilepsy, the green is the epitope, and the three circles are the various types of antibodies that can go bind onto these epitopes, masking or creating a picture of self and non-self. This is something that we need to understand. The same picture that you have seen before, the difference between epilept and epitope. The two principles is to recognize and develop antibodies against non-self, ignoring the self antigen. And the second principle of epilept identification is to find out the affinity is largely determined by a small number of polymorphic amino acids which are near the center of the epitope, which is the functional part. Now the diagram that has gone through this whole morning of explaining to us how a combination of HLA allele antigen mismatches versus an epilept sum or versus a mismatch of a single allele. And the concentration should now slowly move into the single mismatch HLA allele, which can make a difference for patients to come. So all this has been incorporated into the HLA matchmaker, the epilepsy registry as well, and I'm going to give you some of my thoughts and what literature has to say. Nothing much more to say rather than this has been the same references from the morning most of our speakers have been using. Low DSA-free survival at 1 year, definitely with a low mismatch is good. Studies have shown that it's less than 7 mismatch in DR and less than 9 in DQ. When it comes to rejection, similar kind of picture, similar reference. And this is another article that Feroze had put up, which almost says that the non-adherence, something that's very painful for a physician to see and bear after you spend your time and energy, and when the patients, either for lack of finances or just decided that I'll stop. When you see that for a single allele, you can have a much more higher load of epilepsy. So medication non-adherence has been shown to show an increase in epilepsy prospectively. This is a single center retrospective study that was done. So with any HLA antigen mismatch, the epilepsy variability is there for DR and DQ. So as of now, from this paper, which I could understand is based on the retrospective studies that they have done, prospectively it could help us in helping us to how to minimize the immunosuppression, how to handle the tacrolimus so that we can prevent complications. Remember, we bring the patient right towards transplant, high risk, low risk, and then for the lack of money or lack of finances, we say we cannot do a DSA surveillance after post-transplant, which is not, the cost of doing a transplant is even much more higher than that. So, and our patients have one good chance, so let us give them a very good chance. Medical non-adherence, you can see the incidence of class 2 DSA was 2.7 times higher when TAC levels were low. There was an increased DR-DQ antigen mismatch that also happened, which led to the development of DSA and low TAC levels. So this was again further when they did the subgroup analysis, they showed a TAC level of a threshold of less than 5 actually preceded the development of a rejection. So be very careful when you do a reduction of your tacrolimus. Invest in trying to maintain a graft. So TAC trough levels can be modulated, and people who have a very high mismatch score, again, you can risk prognosticate. This is the message that I'm going to keep going and echoing what Feroze has always said. So the degree of the alloimmune risk and the low levels of TAC define the development of DSA. This is something that we should be aware of, and what is that alloimmune risk is something that we still have not got a good grip in. It helped us to minimize the immunosuppression to prevent infections. Then came with all this concept of the algorithm software and the molecular mismatch load. You have quantitative and qualitative. Feroz, Ankit, and has spoken all that in the morning. HLA matchmaker, this went on to go on to develop the 𝑡𝑟𝑎𝑠 epitopes. Remember, these are only done on limited number of samples. And I've kept the limitations in each of this allocation that the software that is being used. So when people already thought about, publications started coming about epilept, HLA mismatch, people always slowly started thinking of T-cell alloimmune response. We are all talking about B cells. What is that? What about T-cell that also plays a very important role? And what about the basic molecular level? That is where all this physiochemical properties and all that was included to look at the immunogenic potential. And Kozmopoulos et al. Brought in this electrostatic mismatch score. Now, these are all computer software generated programs, which depends on what you feed into the software, giving you formulas to look at it. So over a period of time, if you're going to keep depending on AI, we all will lose this ability to think. So we should be very careful of what we are trying to do. Have a prospective look as well. And then finally, Leiden et al. Had brought in the EMMA, epitope mismatch algorithm, which identifies the polymorphic soluble accessorin present on the surface of the LA. Now, this concept of epitope or epilepts, what I would say is, came in, those that are on the surface is the most immunogenic rather than those ones that are in the center. So when you're looking at applying these softwares in the labs, you need to take one more thought about whether you really need to do it or not. And thanks to Antonio, he sent me this paper and I actually worked myself backwards from this paper. This paper finally said, okay, let's do one thing. Let's combine the whole thing and let's see the whole thing, the whole software, and run it on retrospective studies. So it's a good thought. It's not very easy to do a randomized control trial or a prospective study. It's not very easy. And they included all the 3 types of these kind of softwares and tried to see how things were doing. The approach said the HLA DSAs are accepted as high-risk groups. Patients without preformed HLA-directed memory, but with at least one HLA mismatch, account for the most of the transplantation, so they should be classified as immunologically standard risk group. Now, this standard risk group this group was still very heterogeneous because it was based on retrospective studies. And the argument they said was the limitation of the traditional HLA, which they say does not give you the molecular structures on the HLA molecules, epitopes, which are the true targets of alloimmune response. True, I agree to it. This paper then said, look, let's see whether it can risk stratify or improve the risk prediction because of the epileptic post-transplant, because both the cells stimulate an alloimmune response. And this might give you more information on the immunogenicity of individual epilepts. So they brought out this low-risk group, high-risk group, and the intermediate risk group. And they looked at the target outcomes. And this was based on the 3 scores that they had put in for conducting of the study. Very evident that there is a risk stratification that this software is able to help. Looking at the outcomes, increased risk to develop rejections with those who have more mismatches, the higher use of T-cell depleting antibodies to treat the T-cell rejections, which is actually a predictor or a marker of an alloimmune response. And some of these patients who were followed up 5 years, most of the data that you all need to understand is coming in the first year, second year. But this paper said, look, 5 years later, these people go on to develop de novo DSAs. So some important questions or observations which you can notice in this paper is, there's only a top 10 immunogenic epilepts alone had been taken into consideration, and they were noted significantly not associated with the development of rejection. The sensitivity increased to identify a high-risk patient. That's the first thing. The separated score says the reports of D and DQ mismatch, they agreed to it, but when they combine the scoring system, the effect is not seen. But still you saw T-cell rejections. So it cannot be just HLA alone, it cannot be epilept alone, but it has to be a combination of labs or tests that we need to do to ensure a safe transplant. And patients that had an HLA associated but no HLA DSA formed still, as I said, had a T cell rejection, which was preceded by the de novo DSA formation. Now, as usual, there are few limitations. Single center studies, population not large, but had statistically significant results. The moment that is seen, everybody jumps in. Clinicians should not jump into just because it's statistically significant. See it whether it makes a clinical sense. So depending on the characteristics in the HLA background, you need to have a cohort that you can investigate. And that is where we all, as a multi-center, needs to come in to develop our cohort for our country. So what sustains compatibility? This is a journey. And in this journey, what is most important is not who's with you. It can be either a tiny dragon or it can be the panda, but it's actually the company. Now, that company defines the compatibility of relationship. It all depends which company you want to take along with you, along with the patient for this journey. So from a nephrologic perspective, it is a way forward. It's a teamwork. Crosstalks, constant communication between the clinicians and the HLA team is the most important, instructive way to learn to do how a safe transplant. We need to put both together. You cannot run it isolatedly or look at papers isolatedly and say it makes a difference. Crosstalks. So when you look at the delivery of literature of the last 15 to 20 years, the HLA mismatch load computation algorithm showed statistical power in identifying populations at risk in retrospective studies. For the kind of situations the investigators who win, that would have been only the choice left. But are these tools ready and sufficient for implementation into clinical practice? So that is how this epitope matching or came into place. Personally, I still feel it is still at the infancy stage because of the different perspective of the immunogenicity between a donor and recipient to initiate an immune response. So the clinical studies and epilet mismatch, when you look at solid organ transplantation, all these studies had come into a conclusion, which I have just summarized, saying there is a strong positive correlation between class 1 HLA with the triplet mismatch, anti-HLA antibodies, especially in those who are coming for second transplant, or when they have a pregnancy association. And subsequently, Baby et al. Also showed there is a poor adherence to immunosuppressive medications. Singh et al. Identified some DQ alleles that can be precipitative for highly sensitized following transplant and not DR. So you have kind of have a very mixed information that is going. And hence I want to bring in the concept of thinking, of a change in thinking, of rather than looking at epilet matching, you should look at epilet compatibility. And that is not for an allocation of an organ, but that should help us in the long run doing prospective studies of trying to do a risk stratification. So trying to do a good transplant outcome, we have kind of mixed the concepts and bought in this hype that's actually probably giving a very false hope as well. So there is a little more of understanding that you have to do. And this is a very good article that I would suggest that all of you all should read. What this article I just took this diagram, and this concept of epilept universe, of the AI that does that we all try to live into this virtual world, is something that is affecting us all together. So if you look at this HLA matchmaker software, the alleles from both the alleles of the recipient and the donor, contains them into one bucket. So that is the blue bucket on the recipient side, on the left side. That is one group of allele with all the buckets, epilepts, and that's the allele, and that's the donor. And when you try to see, there are some epilepts that match with the different diagrams that go up, and they put it into the gray box, and that's what the HLA matches shows you. That's a universe that they have created for you to look. You only look at that universe. It doesn't work that way in life. So there is an illusion of identical information that goes up into this universe, which we should be very, very careful. And that paper actually is one of Teresaki's scholars who kind of It's been a very critical view. Anant is one of his name that is reported on it. So looking at all this review of literature, some few clinical pearls, I just want to conclude as quickly as possible. Traditional matching approach has its deficiencies, doesn't give you the granularity. How are we defining epitopes? Is it simply differences in amino acid sequence? Are we talking about epilepts or are you talking about epitopes? We should be talking about epilepts only. Not all mismatches are equally pathogenic. There is a clinical demonstration. You are calculating the molecular mismatch load, but does not take you the immunogenic potential of these mismatches. Only the number of the mismatches calculate, note the weightage. Do not know how it translates into an immune activation. Statistical significance was noted with clinical outcomes, but remember, retrospective studies and query implementation in clinical practice. So the use of molecular mismatch load has been done a lot in kidneys. There are some reports that have been done in lungs. There is a correlation that DSA helps you to find out a load, also tells you the antibodies of some HLA mismatch, not all. So we need to know what is in our population. Number 5, this will help you in risk stratification, not for the allocation of an organ, or suppose the recipient comes with 3 donors, you can sit, do their matching and look, donor 1 is good, donor 2 is intermediate, or donor 3 is really poor. So the risk stratification you will be able to do. We should think about concept of permissible mismatches. You will see that some of those who are highly immunogenic, for simple example, I had a mother who had given his kidney to the son, lost his graft in 2 years, and he was having a rip-roaring single antigen bead, which is running 10,000, 20,000, 𝐺𝑒𝑜𝑟𝑒, who came, and now his sister has come forward as a donor, absolutely clean, no DSAs. I don't know. So whether in this group of patients who are coming for second transplant, whether epilepsy mismatch will help this boy or not is something that we need to look into. So each epilope does not elicit an immune response. It's not proven, but it's still assumed that each amino acid change can affect the immunogenicity activity. Clinical application with HLA tubes, with the HLA lab tools, it's too early to say whether they have, but a closer follow-up post-transplant period is needed. How can we use the molecular mismatch risk group clinically? Divide them into risk groups, follow them up prospectively. And guiding these tools should be used for better matching for allocation algorithms, and we need to develop our cohort. So to conclude, an unmet need in renal transplantation is an accurate definition of individual's alloimmune risk given the donor at the time of transplant. Not easy to get. Epilepsy matching is in infancy. Understanding epilepsy compatibility is more important, which is going to be a fundamental requirement if the field is to move towards precision medicine. Till then, practice medicine wisely and safely. Thank you.
Thank you, Dr. Vinoi. It is an excellent talk on HLA compatibility. So if a patient comes with multiple 2 or 3 donors, what will be your steps or procedures based on HLA typing?
So the live-related, when we look, if suppose a father, sister, and the brother has come, or the father and mother, sister, usually it is first we look, try our best to do an age-matched donation. But usually we go for the father and the mother, see how their risk is. If it is a first transplant, usually it is the ladies who come forward, so mothers usually go in. But when the patient is a second transplant, before we do the medical evaluation, we actually run, if we know the past history of what the HLA was or the HLA serology was in the past, it's a very good help to compare with the current donors. So we'll run the cross-match. We do CDC. We will not stop doing CDC. So we do CDC, flow, and single antigen bead. And then we will compare the both and see which is the least immunogenic. That's how we'll move forward.
Thank you, Vinoi, for the nice talk. The relationship between the recipient and the donor is a continuous process, a dynamic process. So we all talk about what happens at the time of transplant. But then for the graft to survive for many, many years, many other factors are also important. Like many things happen, non-compliance with the drugs, infection, so many things can affect the graft survival. In fact, some patients actually do well with even with very little immunosuppression.
Yes.
Some patients who had transplant in 71 in Vellore with no HLA matching survived for 30-40 years with minimal immunosuppression. So the question is like, is there any connection between tolerance and epitope compatibility or difference?
So this concept of this epitope and epilept all came in, actually the initial studies all started with viral infections that was causing the problem, which is activating these epitopes, which most of us are all now immune to it. Or even for a pregnancy, when you're exposed to most of these antigens, some of them become self-antigens, which might play a role in tolerance. So this epilept mismatch at the molecular level, if we are able to identify for all the alleles, it is good. Why some still do, it's only from a larger data set we'll be able to know. Sir.
Hi, Vinoi. Great
Hi.
talk. Nice. Will you be looking in the future where, and we will be looking into the do you foresee something like anti-epilet antibody and forget about the rest of the DSAs?
No, never. I don't think that time will come. I don't think so. We just bought in the concept of, we look at HLA antigen concept when we all started. We are now just looking at the concept of antibody binding, but I don't see anti-epilept antibodies coming in. Because before that, I think they will find out which is actually permissive antigens. And then you'll know the epilepts for you to tell you which is good or not.
You know, we are slowly moving into xenotransplantation as well, which means there is no compatibility at all. Like, you know, recently the transplant which was done in Harvard, pig to humans been surviving with multiple immunosuppression. So with good immunosuppression, can we say that, can we do away with HLA matching?
Actually, I really don't know the answer, sir, but if they say from the literature that we have with the xenotransplantation, definitely HLAs are not going to make sense. It's only going to be the epilepts at that level that is going to see if it's going to be matching. I'm not very sure. I'm not very sure. But if it's epilepts that's only going to be looking between two groups of species, then it should be okay, I guess.
Any other questions from the floor? I think we'll wind up the session.
Thank you.
Dr.
Thank you.
Vinoi.
Thank you, sir. I request Dr. Vinoi Ghegh to stay back on stage. I kindly invite Dr. Dolly Daniel to present memento to Dr. Vinoi Ghegh, Dr. Abby Abraham, and Dr. Jose Paul. Thank you, ma'am. Thank you, sir.
I'm honored to invite Dr. Noble Gracious